We're going to move on to the inguinal and neuromusculoskeletal examinations of the upper and lower extremities. This is a bit of a potpourri of systems checks for the patient because you're going to be looking at the integument, you're going to be looking at the vasculature, the neurologic system, as well as the musculoskeletal system. So it's a little harder to organize in your head. We'll be reverting back to the typical sequence of inspection, palpation, percussion, and auscultation. And so you can use that to try and help you memorize these steps in this somewhat diverse part of the examination. We have left our patient, who we just finished the abdominal exam on, in the supine position with his knees flexed. The gown has been folded down over the patient's lap, and you can give them back that upper gown at this point, but you don't want them to put their arms back in their sleeves. You want to just tie the gown around the patient's neck because this is going to afford us good exposure of the shoulder and back later on in the exam. So we're going to give the patient back a little bit of upper body coverage. There you go. Okay. We also are going to have the patient straighten their legs out, and then we're going to be changing the drape to expose the inguinal regions, which is what we're going to examine next. And to do this, we're kind of going to fold the drape between the patient's legs, and then as we examine each inguinal region, we'll be getting good exposure of that. When you do the inguinal exam, you're going to want to expose the patient's inguinal area from the inguinal ligament down. This is best accomplished by having the patient externally rotate their legs, and we're going to do this primarily one at a time. You could have the patient externally rotate both legs at the same time, but I think that is an awkward position for the patient to maintain for very long. So my choice is to externally rotate one leg, do the exam of the inguinal region, externally rotate the other leg, and do the exam of the other side. There is one point, however, where it's important to compare directly from side to side, and that's when you're palpating the femoral pulses, because you really do want to feel the femoral pulse on one side, then feel the femoral pulse on the other side, because you can compare their strength. There may be important implications to an asymmetry of the femoral pulses. So I'm going to kind of show you how I manage that. I'm going to have our patient externally rotate this leg, and then we're going to get our gown and drape so that we get good exposure of the inguinal region. You want to first look, do your inspection step for any skin abnormalities or anything that you notice, and then you'll palpate the two major groups of inguinal ligaments, the horizontal group, which lies underneath the inguinal ligament, and the vertical group, which lies over the femoral triangle. You'll do this with your circular skin-moving steps, first the horizontal group, and then the vertical group. And then you'll feel for the femoral pulse, which will lie pretty much right underneath the inguinal ligament. Now I'm going to have the patient straighten that leg, externally rotate this leg, expose that inguinal area, and feel for that femoral pulse on the other side so that I can compare the two femoral pulses while I still have a sense of what the other one felt like. You're looking obviously already at the area, then palpating below the inguinal ligament for the horizontal group and over the femoral triangle for the vertical group. You can then have your patient straighten their legs out and listen over the femoral arteries for bruits. You'll do this with your bell for bruits and listen, and then listen. Okay. Then you'll move to the bottom of the examining table and do an inspection of the patient's lower extremities. Now you can see pretty much the entire lower extremity. You want to be looking between patient's toes and the bottom of their feet. You want to feel or palpate for edema at this point. And to do that, you'll put pressure over the anterior surface of the lower leg, and then feel over the areas where you've applied that pressure to feel for any kind of pitting or indentation. You'll also do this over the dorsum of the feet, press, and then feel for any indentation. Subsequent to that, you feel for the pulses. The dorsalis pedis pulses you feel bilaterally and simultaneously, and then tibialis anterior, again bilaterally and simultaneously. A couple tips. Don't feel for pulses with your thumbs because you have a pulse in your thumb and that can be confusing. Sometimes if you're having trouble finding the pulse, getting down sort of at the level of the patient's pulse can help your fingertips be a little bit more sensitive. And you are always wanting to be comparing them simultaneously to see if there's a difference. Okay. At this point, you're going to let your patient sit up. Go ahead and sit up, and you're going to re-drape the patient a little bit so that they're a little more comfortable. And you'll be looking at the upper extremities. You can see that with the gown like this, you've got good exposure of the shoulder line, so that when you look at the upper extremities, you get a good look at the skin of the shoulder, the upper arms, the lower arms, etc. You want to look at the patient's hands, fingernails. Then you can have them turn their arms like this and feel the radial pulses bilaterally and simultaneously. Next, we'll check for pronator drift. You want the patient to hold their arms up, palms up, and then have them close their eyes. And you're watching for any lowering or pronation of the arms and hands. Good. All right, you're all set. After that, you're going to test for distal strength. Have the patient grab your two fingers and pull. Don't let you out. You resist, they pull. Excellent. After that, you'll also check for any change that you have obtained in the lower extremities on dependency, so you'll feel for any temperature change with the back of your hand. It's normal for the lower extremity to get cooler as you get to the periphery. You want to just be feeling for whether that's a symmetrical change, and you want to observe for any change in skin color or vascular problems. Okay. We're going to test for proximal hip strength by having the patient lift up their knee against pressure. Lift, you push. Lift up the other knee, you push down. Good. It's important to do this with the same hand because if you're right-handed and you do one with your right hand and one with your left hand, the difference in your own strength may lead you to believe that there's a difference in the patient's strength. So you want to do that with the same dominant hand. Okay. We're going to move on now to the deep tendon reflexes. This is another technique that will probably provide you with some challenge. This is a reflex hammer. In order to have the reflexes elicited most efficaciously, you do want to let the reflex hammer do most of the work. A lot of the problem exists when you try to do the work for the reflex hammer. You want to let it basically drop through its arc, so you want to hold it kind of loosely at the end. Another important thing to remember is that you're always going to do reflexes and compare them directly side to side. You won't do biceps, triceps, brachioradialis on one side and then move to the other side and do that. You'll do biceps on both sides, triceps, both sides, brachioradialis, both sides, patella, both sides, ankle, both sides. Because what you're looking for is really less the absolute value of a reflex and more the comparison from side to side. You will pick up more disease processes by picking up an asymmetry than you will deciding whether someone's got 2 out of 4 reflexes or 4 out of 4 reflexes. So let's start with the biceps. You want the patient's arm in a relaxed position. You want to put your own finger, and this can be your first finger or your thumb, depending on what's most convenient for you or what feels better, over that biceps tendon. You've got a relaxed arm. Let's tuck that in so we can make sure people can see. And then you want to strike your finger. You can see this patient's got great reflexes. And you get your reflex. I can do that with my thumb, if my hand is big enough and if I can reach it around. That's a lot more precise than trying to hit the tendon directly, because you've got it under your finger and you know that you're getting a good striking. And again, you can see my hammer basically doing the work for me. I'm holding it very loosely and letting it just sort of fall through its arc. So you look at that reflex on that side, you come over to the other side, you try and get the arm in a similar position, similar orientation and state of relaxation. Find your tendon, and again, strike it. The harder I strike, the brisker his reflex is. So I've got to try and standardize my own technique so that I'm striking with about the same strength on one side and then the other. And these are symmetrical reflexes. Let's move on to the triceps. The triceps tendon, I'm going to let you sort of relax your arm and just hang it over mine, is located right here above the elbow. Lots of times the smaller point of your reflex hammer will fit in there. Get your patient to just try and relax their arm and then watch for contraction of the triceps. Do the same thing on the other side. You'll probably see it better here. Go ahead and have your patient just hang their arm. Try and get them to relax. Go ahead and strike that tendon and watch for contraction of the triceps. Those are good symmetrical reflexes. Brachioradialis. Usually you strike that tendon about an inch or two above the wrist, medially. You can see there that contraction. Again, arm position, hopefully symmetrical. Strike the tendon, let the hammer do the work. The flat side of the reflex hammer is usually best for this because you're aiming for a small tendon and you may well miss it with the pointy part. You can probably do these even without moving from side to side on the patient. Try to standardize your strike strength and you'll get reflexes that are good and symmetrical. Okay? Now we're going to do the knees. It's best if your patient's legs are hanging, depending on how tall your patient is and how big your examining table is. You may or may not be able to make that happen. Can you scooch back a little bit? Let's see if we get, okay, go ahead and let it hang. And we're going to, again, be striking the patellar tendon, trying to standardize. Now see that? Brisker on this side, then on the other side, I'm going to try and standardize my technique and I get my symmetric reflexes. Lastly, the ankle reflex. You need your patient to rest their foot in your hand and relax their foot. Take your flat end of the reflex hammer and strike the Achilles tendon and you'll get your visible reflex. Let's do it on the other side, a relaxed foot. Strike your tendon and you've got your reflex. Okay, good. That ends the reflex portion. Now we're going to have our patient actually stand. And to do that, we're going to actually remove this drape and let our patient stand up. You want to help your patient down and up. You've got the gown so that you've got good exposure of the shoulder line, and you're just going to look at the patient's station. Go ahead and stand with the shoulder line, symmetry, arm carriage. All right, now we're going to have our patient walk. Can you walk away from me, just your normal gait, and then go ahead and walk back. Good, you're observing their gait. Now can you walk away on your toes? You'll be looking for the ability to do that, distal strength, and back on your heels. Good. Now I'm going to have you turn around. Now you're going to see for the first time the skin of the back of the legs. You want to be looking for any dermatologic abnormality. You can also get a good sense of the symmetry of the shoulder line, the hip line, gluteal folds, back of the knees. You're going to have your patient lean forward as if they're going to touch their toes. Go ahead and do that. And again, look for spinal alignment. If you haven't already seen the skin of the coccyx, you will here. Have your patient stand up. And you're ready to go back and sit on the table. Go ahead. That basically completes that portion of the examination.